Hello everyone, myself Ben Samuel, Application Specialist at AD Instruments, and I'll be your moderator for this inaugural webinar of the APPI-ADI Application Webinar series, mainly centered towards autonomic function assessment through quantification of resting cardiovascular variabilities. This webinar aims to delve into the latest advancements and practical applications of heart rate variability and AFT across diverse domains. The collaboration between academia and industry acts as a driving force for progress and innovation within the realm of medical sciences. Aligned with this principle, ADI has established a strategic partnership with APPI to promote advancements in physiology, pharmacology, and related fields. As a part of our joint efforts, we introduced the APPI-ADI Application Webinars tailored to facilitate an exchange of scientific breakthroughs and support professional growth. We are thrilled to have such a diverse and engaged audience joining us from around the globe. Whether you are a seasoned professional in the field or someone eager to learn more about AFT, your presence here today is greatly appreciated. We encourage everyone to actively participate, ask questions, and share insights throughout the session. Your contributions will enrich our discussion and make this webinar a truly collaborative learning experience. I welcome you all once again to this webinar. Now, it's my pleasure to introduce our esteemed panel of speakers, each bringing a unique perspective and wealth of expertise to today's discussion. Professor K.K. Deepak, Visiting Professor, Center of Biomedical Engineering, IIT New Delhi, and former Professor and Head of the Department Physiology at AIIMS New Delhi. He'll be taking us through the overview of autonomic function evaluation. Next up, Dr. Shival Srivastava, Associate Professor, Department of Physiology at AIIMS Jodhpur, and he'll be taking us through HRV assessment and the Ewing battery of tests. Finally, Dr. Kiran Prakash, Assistant Professor, Department of Physiology, Government Medical College Hospital, Chandigarh, and she'll be taking us through the newer techniques in autonomic variability quantification, including BPV and BRS. We are privileged to have such an esteemed panel of speakers with us today, and I'm confident that their expertise will provide valuable insights and inspire thought-provoking discussions. Please join me in extending a warm welcome to our distinguished speakers. All right, we'll move on to our first topic without further ado. So our first topic will be the overview of autonomic function evaluation by Professor K.K. Deepak. It is my distinct honor and privilege to introduce Dr. K.K. Deepak, a distinguished authority in the field of autonomic function testing, a prominent figure in the field of physiology, and an innovator in biomedical engineering. Professor K.K. Deepak is a distinguished visiting professor at the Center of Biomedical Engineering at the Indian Institute of Technology, Delhi. Professor Deepak's pioneering efforts include establishing India's first autonomic function lab in 1989 at AIIMS New Delhi, which has since become a hub for clinical services, research, education, and technological advancements in the field. His expertise in this area has led to the supervision of over 125 theses and the instrumental establishment of autonomic function labs in several medical institutions across the country. His innovative spirit shines through his involvement in developing cloud-based analysis of heart rate variability in collaboration with the Digital India Corporation. Additionally, he established India's first vascular function lab in 2000 and recently launched the first formal biofeedback clinic at AIIMS New Delhi in 2023, demonstrating his commitment to advancing healthcare technologies. He started the Space Physiology Lab at AIIMS in 2013, the first in India, and continues to the R&D. Recently, he has been granted a patent for a pro-gravity body gear for astronauts. Professor Deepak, also an inventor in 6 more patents related to isometric exercise, human muscular fatigue recording, other innovations in space physiology. Dr. Deepak has received numerous awards and recognitions for his outstanding achievements, including the prestigious 7th Dr. B.K. Anand Memorial Award in 2020. His research interests include space physiology, autonomic function measurement in humans, and the application of yoga in healthcare. Professor Deepak's expertise extends to human system modeling, where his research promises to revolutionize our understanding of human body. His prolific output includes over 230 research papers, boasting a H index of 36 and accumulating over 4,900 citations, reflecting his significant impact on the scientific community. Recently, he has been appointed as the Early Mid-Career Education Research Engagement Chair of the Federation of Asian and Oceanian Physiological Societies, the highest position occupied by any Indian in the FAOPS. He has also served as a chairperson for Fit India protocols and guidelines. In today's webinar, we have the distinct privilege of delving into the realm of autonomic function testing under the expert guidance of Dr. K.K. Deepak. Through his profound insights and wealth of experience, Dr. Deepak will shed light on the latest advancements in the field, offering invaluable perspectives that promises to enrich our understanding and practice. Please join me in extending a warm welcome to Dr. K.K. Deepak as we embark on this enlightening journey into the realm of autonomic function testing. Thank you. Over to you, Dr. Deepak.
So, good afternoon, everybody. I'm here to talk about overview of autonomic function evaluation, and we've been working in this field for quite some time now. It's been over 3 decades, which is a small time in the development of a new concept, technology, and evaluation. So, this is what is the plan? The plan is to tell you something about the need, the technology, our data, and some new applications in clinical scenario with reference to autonomic functions. As you may be aware, autonomic dysfunction may involve multi-systems. Those clinicians who are sitting here in day out, they observe symptoms like sweating, diarrhea, fall in blood pressure, and the several problems. So on the right side, you see the diagram. Autonomic nervous system is a control system which is supplying almost large number of organs you see here, all vessels and all other places by which the smooth vasculature, by which they supply the control the logistic part of the body. So this has to function very important, and when logistic function takes place, then that's what we survive. So by this, several symptoms are created. So there's an abnormality and symptoms will be created, one or more. So it is very important to quantify and monitor these symptoms and control systems. Not only symptoms, that how much sweating you have, how much tachycardia you have, also how it's being controlled. Is there a defect in the control system? Is there a problem with the control system? So ANS testing is basically a testing of a control system. Therefore, this is very useful. The need of autonomic evaluation is very important. It is useful in defining the presence of autonomic dysfunction, to provide differential diagnostic information, and or to quantify autonomic function regarding their natural history and response to treatment. This is very clear. Suppose you have diabetes and you have problem with your vascular regulation of autonomic controls. Therefore, you will have several symptoms like fall in blood pressure, sweating disorder, the sexual dysfunction, and so on and so forth. So therefore, it's important to monitor, and they help in various ways. Let's see how they help. So the most important function of these AFT is to establish is there loss with reference to autonomic fibers, which are basically sympathetic C fibers, exclude CNS etiology when the results are deranged, because it could be the controller which is a defect, or it's a vascular or smooth muscles. So this kind of a link which is there. Also to predict prognosis, and it has been said that HRV heart rate variability, which can be determined in autonomic quantification control systems, actually can predict the second level or third level of heart attack, and therefore it becomes very important. And that part we come a little later. So it's also do a prediction and differential diagnosis in several areas like POTS, which is paroxysmal orthostatic tachycardia syndrome, or to differentiate multi-system atrophy of different types. And therefore, it's important. Again, my question: why monitor autonomic functions? So again, as I told you, to establish, to monitor, and to detect. And there are several categories which fall into each one of them. Therefore, it becomes very important to monitor this function. Once you have established the loss, how this process takes place. In fact, we have some published papers in which we monitored autonomic function loss because of lead toxicity. And then we found that if you do a chelation of a lead and then you find that it comes back. Had this not been available monitoring, it wouldn't have been possible for anybody, for gastroenterologist or neurologist or anybody to know what is happening with the, after lead toxicity and lead chelation. Therefore, it becomes very important. And this also we did several other cases in which the autonomic drugs which are given are being monitored for a patient of hypertension. So this is important to monitor. They can provide several answers to the questions which clinicians have, or several answers to the questions which researchers have. It could be a physiologist or clinician or a diabetologist or so. Where is the lesion located in the brain? Neurologist would need it most. Which particular branch is affected? Again, if they have to do blocking, like several cases were referred to us for sympathetic blockade for facial hyperhidrosis of patient of then they would look for which particular area is affected, which can be quantified by pseudomotor test or several other organ function tests. What can be possible differential diagnosis? As I told you example of multi-system atrophy of Parkinson type or some other type which can be differentiated. It's a cerebral ataxia of a different nature. So that can be differentiated. What further workup is required? So what kind of intervention is required? Can drugs or medication alone control it, or you need alternative approaches, which could be physiological. For example, it could be exercise, it could be yoga, it could be meditation, or it could be biofeedback. So I'm going to give some example of biofeedback. How can the management be charted? And therefore, once you have all data, a history of data sheet on autonomic loss, there you can chart your management. And that's very useful. And it's a cost-effective and reliable tool for which several studies have been already published.
Sir,
Yeah. Are you
sir,
able?
sorry to interrupt you in between. Sir, there is some voice disturbance.
Oh, 1 minute.
Sir, can you unmute? Sir, can you unmute, please?
Okay, am I audible now?
Yes, sir. Yes, sir.
Okay, right. I think. Is it visible? The full screen is visible?
Not yet, sir.
Yeah.
Yeah, it's visible now.
Okay. So sorry for this interruption. What are the methods of measuring autonomic functions? My two colleagues are going to speak in details, but I'll just take an overview and try to tell you how this thing can be done. And there is a direct method by measuring directly from the nerve or chemicals, catecholamines. Indirect method by autonomic activity, heart rate variability, bioflex sensitivity, and indirect method associated with the exposure of physiological stimuli. For example, you give a cold stimulus or hot or head up tilt, and that falls in Ewing's battery. The first two, they measure the autonomic activity, which is a basal tone. The last one measures the reflex or reactivity part, and these are the reactivity tests which can measure sympathetic and parasympathetic, and these are the classical tests described in Ewing's battery. They could be a set of change. Some one of the tests may be replaced by some other test. So these are the important tests for autonomic reactivity testing. And there are several other tests which can be included in the battery depending on the need. Pseudomotor function related to sweat, pupil function related to eye, or GI function. And there you need to know what to do, how to do, when to do, and interpretation. Once you know this, you can devise your own test. So there's a possibility that you can devise your own test, and there are several tests of autonomic functions. So here the list provides you the levels of difficulty and feasibility. So they can be low, medium, high, very difficult depending on the cost input or technology input. And therefore, the one in blue can be easily done by any of the laboratories across country anyway. So what we have done, how we have contributed to this understanding of this, we started way back in 1989 with the 5 aims: clinical testing, research, capacity building, technology development, and database management. We've gone through the full cycle of from scratch, from nothing in the country to the level of referring patient from other clinical departments, and then we further introduced several other technology. So our input to the clinical physiology, especially the autonomic, has been substantial and documented and published to provide clinicians a definitive value of autonomic loss, to provide consultation to clinicians, to provide insight into the intervention. And we have gone through boundaries of physiology to the clinical scenario to perform all these functions, and our data speaks. And therefore, the academic growth has happened. We have reported work done in different levels of autonomic losses or intervention. We have worked on AFT testing itself, physiological responses, physiological insult, and several diseases. And several diseases include a large number of diseases which have already been published. And we took up several projects where autonomic loss were reported, and then we have gone both to the clinical services as well as the academic research and publication. We collaborated with several disciplines across the hospital. AIMS is the #1 premier institution, and not only the different clinical departments, not only medicine and surgery, but we also gone to develop and do research with other institutions like several IITs and in sports sciences, where exercise physiology is an important autonomic parameter. Over 20,000 data set is available at AFT lab. So when I left last year, I moved to IIT, we had about 21,000, nearly about 22,000 cases, and it's a national heritage, and it's a big data which is available. The data itself speaks about the phases of development. And more than 100 cases alone in autonomic has been done. And we have large number of communication and publication. So we attracted large number of basic research, clinical research, and other for enhancing. So what is a new application? People always talk about whether it's been old and many people have been doing, but we innovated how autonomic results, autonomic functions can be applied. So one of the important which we started long back, 30 years ago, but we still continue, characterization of spinocerebellar ataxia, which is a very significant disease, results in autonomic dysfunction. And we showed by doing a concomitant MRI study with the loss of autonomic function recording and try to see which of the areas are involved. And we did the composite autonomic severity score and also try to find out the basic question, and which came up to the light, is that is there laterality in autonomic control? The question I've been addressing for over 3 decades, and we've been trying to prove by this, like right and left side, whether the input point of view, sensory point of view, or the control point of view, and there are indications. Our own research here shows there are indications of differential involvement in the autonomic. The way we have right-handed, left-handed, perhaps there are people who have a right-handed and left autonomic and right brain autonomic controls. And this is the area speak volumes. 2019 only a review appeared by Jimison and Spyman. They have tried to see the left and right change in conduction over time when you stimulate left or right side in a patient of left hemispheric stroke. Something similar study we carried out in one of the listed here in 2006, differential hemispheric blood flow to the partial challenge. And therefore, it is important for the new generation to look into the laterality of autonomic control. Then, can autonomic parameters be used as a classifier for spinocerebellar ataxia by using a machine learning? So we went into machine learning approach, by using a machine learning approach of a different type, that is a LDA, linear discriminant classifier, and support vector machine. And we found that yes, it can be used as a classifier. Earlier, people have reported use of autonomic parameter to classify arrhythmias. And therefore, this is an important tool and it's a future implication for classification of a disease. This is the one paper we published and we are very proud of it, that we reported a difference in the new method of autonomic scoring, which we developed at AFT when we compared with the classical one, Ewing's and Bellevue criteria. And we found it is more useful for reporting for the diabetic, especially because the diabetic picture in India is different from the Western picture, which has been quoted in the book. So therefore, we can always think of a new scoring method which can give you a better insight. Another thing which we started, autonomic biofeedback, in this case of a lady having severe loss of autonomic dysfunction and having several episodes of postural hypotension, every day we gave a systolic pressure visual biofeedback intervention. And then we found that the lady could improve her blood pressure by 20 millimeter and by therefore avoiding the syncope or blackouts. So this is one of the new applications. Early people have reported HRV biofeedback. We've also been working on HRV biofeedback for stress or a specific disorder. So this is another area which opens up. Recently, we reported lower BRS, birth sensitivity, in COVID survivors. And BRS is nothing but the key indicator of autonomic loss with reference to cardiac and vascular. So, besides this, we have gone in for the capacity building and technology development. And then we developed our own software, HRV soft, for doing HRV, and also BPV, blood pressure variability soft for doing this blood pressure variability analysis. Therefore, we could compute BRS by our own software. And we did a multi-center trial from here to Nimes, Bangalore, and several other, and then this is what has did a capacity building for understanding of HRV way back in 2006 and then onward. We developed our own cloud-based system for doing HRV analysis. We have been giving training and workshops on this, and this is what the next generation is here to take this call for further. So this is what is a contribution to indigenous development for technological innovations. There are several devices we developed with reference to autonomic. The first one is the blood pressure simulation model, which was used by NASA. Second one is the fabric, which can kind of a shirt where you can use the wireless monitoring. We did validation, single channel ECG machine we developed with the DST. India's impedance plethysmograph we have validated, and it has been used in large number of for devices. The unique part is it could quantify blood flow variability, and therefore, so this is still being marketed by Scanner for cardiac output monitor. HRV and BPV software I have already spoke. We took up an Grand Indo-US challenge and developed our own blood pressure sensor for continuous blood pressure monitoring. Antibody body gear and its effect on cardiovascular parameter we have already published. Computerized mosaic and looking for other vascular changes locally that we are working on. And this is the one tech development. It is India's first NIVP attempt. And we started doing, we have published the first part of this about the characterization of where we put a pressure sensor on a skin, and therefore we were able to reproduce this. So this is a novel modular tonometric based device to measure pulse pressure waveforms in very largely. The current status in medical education and clinical care is important. The Harrison principle of internal medicine, which is the textbook, like it's called a Gita for medical sciences, medical people, medicine people. Now it describes test for autonomic dysfunction. It's a textbook which is describing, and it says what loss of function. In India, we started in 1990s. We convinced MCI, now NMC, to include this in the curriculum. So it has been included in education. So it is a part of most of the physiology department. They have now AFT testing lab. Also, some of the neurology department they have it. It has been approved by American Academy of Neurology, and there are different indications available where AFT testing should be done, and there is a clear indication of clinical indications for testing, and there are several of them are available. The list is large, therefore it becomes important to do this testing. And this is further in ICD classification 9 and 10, again published by American Academy of Neurology, where autonomic testing model coverage policy. It is there. So these are all disorders which you see here where the autonomic functions should be tested. And therefore, so my agenda should be for the future is we should have normative value for the country. And we have already started doing this. Some publications have already come out from our colleagues across country. Diagnostic and prognostic implications, studies of autonomic test, the new test we should develop, and we should prepare guidelines. So it's important work which we can carry out in the future. With this, I come down to closing. We have a large number of colleagues who have been collaborating since 90s now, and then large number of people with whom we have collaborated, and we acknowledge funding agencies and technology development. And without technology development and new equipment, this could not have happened. So many of the private players have come up to provide the equipment in this area. So now, thank you so much for listening. This is over to the young generation. Thank you once again. Over to organizers.
Thank you so much, Professor Deepak. We encourage active participation by the participants. So if you have any questions, feel free to put your questions in the Q&A session, and we'll be answering it like towards the end of the topic, or it will be answered to you via Zoom. Once again, thank you, Dr. Deepak, for that insightful presentation. Your expertise and passion for autonomic function evaluation truly shone through, and we are incredibly grateful for the valuable knowledge and insights made the content accessible and engaging for all the participants. It's evident that your dedication to the topic has made a significant impact on the audience today. On behalf of AD Instruments and all the participants, I want to extend our sincere gratitude for your time, expertise, and commitment to making this webinar a success. We are truly honored to have you as our speaker, and we hope to have the opportunity to collaborate with you again in the future. Thank you once again, Professor K.K. Deepak, for your outstanding contribution for today's webinar. We'll move on to our next topic, heart rate variability assessment, and conduct the Ewing battery of tests by Dr. Shival Srivastava. Dr. Shival is currently the Associate Professor, Department of Physiology at All India Institute of Medical Sciences, Jodhpur. His research focuses on the assessment of autonomic and vascular functions in both healthy individuals and those with various medical conditions. His research interests include autonomic function testing, microgravity, vascular function, baroreflex sensitivity, heart rate variability, blood pressure variability, and autonomic dysreflexia. He has more than 30 research articles in peer-reviewed journals and has experience of conducting and supervising autonomic function testing for more than 2,000 patients till date. He has conducted multiple workshops on autonomic function assessment at national and SAC nation level conferences as a resource person. He has also contributed to development of novel AI-based tools for literature mapping and scientific illustration. He is presently the Associated Editor Physiology for the Indian Journal of Physiology and Pharmacology, the official publication of the APPI. Dr. Shival's work has been recognized by the scientific community, and he has received numerous awards and grants for his research. He has received Srimati Shubha Mukherjee Oration Award from the Physiological Society of India, Professor N.S. Dalla Award from the Indian Society of Heart Research, and has won awards for poster and oral presentation at national conferences. Please join me in extending a warm welcome to Dr. Shival Srivastava to share his expertise on HRV and Ewing test. We are honored to have you with us today, and we eagerly anticipate an enlightening presentation, sir. Over to you, Dr. Shival.
Thank you so much. Good afternoon to all the participants and the panelists. I hope my screen is visible and you can see the laser pointers. I'll be briefly discussing the part of the assessment of autonomic tone and reactivity. I'll try to be brief regarding the theoretical part of the aspect of these two things, since much of literature is already available, and we'll try to focus more on the demonstration part and the analysis part of the signals. So to quickly start with, autonomic function testing, as sir has already told, can be done across multiple domains cardiac, pseudomotor, gastrointestinal, pupillary, etc. We primarily work in the area of cardiac autonomic function assessment, where we talk about two key parameters: assessment of the resting tone of the system, cardiac autonomic tone, which is assessed using heart rate variability, and assessment of response to stimuli, which comes under the ambit of cardiac autonomic reactivity. Reactivity means the response to stimuli. This battery of tests was proposed initially by Ewing and Clark, which had multiple tests which were there. Some of the tests were right there from the start, number 1 to 4. Cold pressure test was not part of the initial battery by Ewing and Clark and was added later on. So in my brief talk coming ahead, I would like to just focus upon, is there a gold standard test? Why should we use the battery of test? Is Ewing's battery valid? Can we use some other battery? What is the standard way to perform, with some emphasis on the analysis part, some outcome measures that we can expect from the test, and the grading part. What if the patient cannot perform on the test? And we very well know what are the clinical conditions wherein this battery can be used, which sir has already discussed. So starting with the first point, there cannot be a single gold standard test for autonomic function assessment, as the supply of the autonomic nervous system is very broad. There are different afferent and efferent pathways that eventually converge and lead to changes in blood pressure and heart rate. That is why there is recommendation of use of a battery of tests rather than a single test for the purpose of autonomic function assessment. Ewing battery is the most common and most reported battery that is used for this purpose of assessment. There have been some other criteria, some condensed batteries also. They are also valid, but this remains the most popular and widely used battery. And how to perform this and what are the outcome measures, I will discuss in the later part of my talk. So we very well know that autonomic nervous system, basic physiology, gives synthetic neural supply by means of the intermediolateral column of the spinal cord. Here will be focusing primarily on the response at the level of the heart and the vasculature. Adrenal gland acts as a peripheral ganglia, releases vasoactive substances, which again supply the heart and the vasculature and lead to end organ effects. Parasympathetic supply is primarily by means of the vagus nerve. So what we are trying to do in this assessment part is we are trying to stimulate these limbs of the autonomic nervous system by giving physiological stimuli such as deep breathing, then orthostasis, Valsalva maneuver, isometric exercise, isometric exercise and cold stimulation. And by means of this physiological stimulation, we are trying to quantify the changes in blood pressure and heart rate and try to compare that with normative data. Assumption in performance of autonomic testing is that the end organs which are responding to this stimulation are intact, and the absence of response, blood pressure and or heart rate response, may be because of afferent and or efferent dysfunction. Different stimuli, which I have shown in my previous slide, invoke different pathways which may have exclusive afferents. That is why there is a need for a battery of tests. A single test will not suffice. And heart rate indices are primarily vaguely mediated, therefore are referred to as parasympathetic indices, whereas the blood pressure responses represent the sympathetic indices and are indicative of sympathetic function. Autonomic function lab can be started with basic equipment such as a aneroid sphygmomanometer, a paper-based ECG machine, and we are able to do majority of the tests, but it is recommended to have digital data acquisition systems to increase the fidelity of the recording and for the performance of the heart rate variability analysis. The basic overview of the signal acquisition part. What we are primarily doing is the conversion of an analog event from an analog to digital conversion using a data acquisition system. In the background, there is amplification of the signal, filtering is happening, and acquisition is happening. And this is finally put into a computer readable format for the purpose of analysis. The first part is the assessment of autonomic tone, that is the resting activity of the autonomic nervous system, which is primarily done by a metric that is known as heart rate variability. Heart rate variability, simply put, is the quantification of beat-to-beat variability in the heart rate, or the RR intervals, also referred to as interbeat intervals in some texts. Prerequisites for performance of this parameter is the existence of a digital data acquisition system. Short-term HRV is done using an ECG recording for 5 minutes in supine position. Long-term HRV for 24 hours is also reported, and this can also be performed using a portable system. This is the representative record wherein the lead to ECG is being shown in the top panel, and we have derived metrics from this lead to ECG, which are heart rate and RR interval. What we are doing in heart rate variability is quantifying the variability in this heart rate or this beat to beat interval over a defined time period, which in the autonomic lab is usually a short-term HRV or a 5-minute window. Some, I may say, checkpoints are required before we record and assess heart rate variability. The recording should be done in a noise-free, temperature-controlled environment. We should have a good data acquisition system with high sampling rate. Minimum sampling rate recommended is 128 samples per second, but the modern systems that are available go well above that and can sample signals as high as 10,000 samples per second. And the duration can be decided based upon your experimental protocol. Usually it is a 5-minute window. No artifacts or ectopics should be there in the recording. We should ensure stationarity, that the subject should be at rest while the recording is being performed. And spontaneous breathing is recommended in literature for the assessment of HRV, while some of the authorities, they also recommend metronomic breathing or paced breathing. But in my personal experience and what work we have done, we find spontaneous breathing to be better. After acquisition of 5 minutes of ECG, we have a tachogram, which is the recording of the variation in the RR interval. You can see on the y-axis, the RR interval in milliseconds. And this is the interval number, which may be time in some of the axes, in some of the graphs. And we can see the fluctuation in the RR interval as a measure of the interval number. Then this tachogram, the values that are obtained in this tachogram can be subjected to basic statistical analysis, spectral analysis, and nonlinear analysis to obtain time domain, frequency domain, and geometric measures. Spectral analysis decomposes this waveform into a power spectral plot, wherein we talk about a very low frequency band representative of respiratory frequency, a low frequency band which talks primarily about sympathetic influence to the autonomic nervous system with some influence from the parasympathetic nervous system, and a high frequency band which primarily talks about the parasympathetic influence. And based on this spectral analysis and basic analysis, we can obtain multiple measures such as standard deviation, root mean square of standard deviation, NN50, PNN50, etc. And in frequency domain, we can talk about the low frequency power, high frequency power, total power, and sympathovagal balance as assessed by LF-HF ratio. I'll not go into the details of all these metrics and normative ranges, as much of it is available in the literature. And you can look for the data that is available for your population when you are recording HRV and assessing whether the parameters are normal or not. The second part is the assessment of the response to stimuli to the autonomic nervous system, which talks about autonomic reactivity. This is done by common maneuvers such as deep breathing, which accentuates the phenomenon of sinus arrhythmia. We know that during inspiration, there is tachycardia and bradycardia during expiration. We ask the subject to do deep cyclical breathing, which 5 seconds of inspiration and 5 seconds of expiration slowly. And this is done for a period of 1 minute, 6 to 7 cycles can be recorded. This is the best cardiovagal measure available. It is usually done in sitting position, and it is advisable to have an analog or a digital stethograph to assess the accuracy and the proper performance of the maneuver. Lead to ECG recording is also required simultaneously. Real-time derived heart rate and RR intervals, which are available with our digital systems, are preferable. So this is a representative record of the deep breathing test. On the top panel, you can see the respiration, inspiration, and expiration. The vertical lines are showing the cycle. So in this diagram, we have 1, 2, 3, 4, 5, 6, and 7 and 8 cycles of inspiration and expiration. And we can see that with inspiration, there is an increase in the heart rate and a decrease in the heart rate with expiration that is happening cyclically with the different cycles of breathing. So this inspiration and expiration we can quantify by taking the maximum heart rate during inspiration and the minimum heart rate during expiration, and vice versa with the RR intervals. And we can derive two key indicators: the change in heart rate, that is known as the delta HR in the autonomic terminology, which is the difference of the maximum heart rate during inspiration and the minimal heart rate during expiration, which is averaged over 6 cycles. EI ratio is the ratio of the maximal RR intervals during expiration here, because this is RR interval, and minimal RR interval during inspiration, This also needs to be averaged over 6 cycles. The second part of the test is orthostasis challenge, that is lying to standing test. Again, basic physiology, assumption of standing posture, engages the baroreflexes that causes characteristic changes in blood pressure and heart rate. We are interested in the fall in blood pressure after orthostasis, primarily focusing upon the fall in systolic blood pressure. The ratio of the RR intervals at and around 30th beat and at and around 15th beat, which is known as 30-15 ratio, are computed. And again, from our clinical knowledge, we already know that fall of 20 mmHg in systolic BP or 10 mmHg in diastolic BP is referred to as orthostatic hypotension and is usually pathological. Again, a representative record, this vertical line showing the assumption of standing posture. We can see that in the heart rate, which is shown in this pink panel, there is an immediate rise in the heart rate followed by a decline, and with some time the values will return to the baseline values. So we can take the maximum RR interval, the minimum RR interval at around 15th beat, this lower panel, we can see my cursor hovering, and the maximum RR interval at around 30th beat, and can derive 30-15 ratio. Valsalva maneuver is performed in the lab using a sphygmomanometer. It is forced expiration against a closed glottis. In the lab, because the subject is connected to the sphygmomanometer, it is being done against an open glottis. To quantify the effort, it is done at an effort of 40 mmHg for 15 seconds. We remove the blood pressure cuff, connect a mouthpiece, which should be sterilized and disposable, and ask the patient to blow into the manometer. In this clock-based dial, the subject will see the needle moving, and we ask the subject to strain and maintain an effort of 40 mmHg for a period of 15 seconds. And after the end of the forceful inspiration, the subject is requested to breathe as normally as possible. Valsalva ratio is the longest RR interval after the strain divided by the shortest RR interval during the strain, and this is an index of parasympathetic function. Again, a representative record, these vertical lines show the performance of the Valsalva maneuver. This is the baseline part. This is the increase in the heart rate during the phase 2 of Valsalva maneuver, followed by bradycardia during the phase 4 part, and the ratio of the longest RR interval after the maneuver divided by the shortest RR interval during the maneuver will give you your Valsalva ratio. Then the other two tests are relatively simple. We are primarily interested in the blood pressure response. One of the tests is hand grip or isometric exercise test, wherein isometric exercise is done using this digital or manual hand grip dynamometer at 1/3 of the maximum capacity for a period of 4 minutes. In the other cold pressure test, we dip the hand up to the level of the wrist in cold water at 10 degrees centigrade for a period of 1 minute. And we are interested in seeing the sympathetically mediated rise in diastolic blood pressure, which usually happens after 1 minute of this cold stimulation, and during a period of 1 to 2 minutes, and may be seen late up to in a window of 4 minutes after doing isometric exercise at 1/3 of the maximal capacity. The next question is that what to report, what to consider. So these are the commonly derived indices which we have already discussed using deep breathing test, Valsalva maneuver, postural challenge, hand grip test, and cold pressure test. And this is the normal response based on Ewing's criteria. So for deep breathing test, a heart rate response of greater than 15 is normal, 11 to 14 is borderline, and less than 10 beats per minute is abnormal. Valsalva maneuver, a ratio of 1.21 is normal, 1.1 to 1.20 is borderline, and less than 1.1 is impaired response, and similar responses exist for other tests also. Then grading can be done based on Ewing's criteria as normal, early, definite, or severe, based upon the test whether they are borderline or abnormal. This Ewing's paper is freely available on the internet, and you can look at the scoring system in this paper. Then AIMS New Delhi criteria, this paper was already shown by Sir in his previous talk, wherein he talked about a paper by Khandelwal et al. Published in 2011. This gives an elaborate scoring and reporting system based on AIMS New Delhi criteria. Again, I would like to draw your attention to the fact that cold pressure test, as shown here, was not a part of the Ewing battery of tests, and it was included later. And based on the, again, the normal and borderline or impaired response, we can classify autonomic neuropathy as non-existence or a normal response, where all tests are normal or one test is borderline. early autonomic neuropathy, one test is abnormal, two tests are borderline, and a definite autonomic neuropathy where two tests are abnormal. Then there are no absolute contraindications for most of the tests other than Valsalva maneuver. The absolute contraindications for Valsalva maneuver is retinopathy, which is maybe because of diabetes, hypertension, or any other cause. So it is advisable for the patient to have a fundus examination before coming to the lab. And if you are unsure about retinopathy, its existence, then it may be prudent to avoid Valsalva maneuver. Implantation of intraocular lens after cataract surgery is an absolute contraindication. Active glaucoma or glaucoma under treatment, Valsalva should be avoided. And any incisional scar on the abdomen leading to abdominal or inguinal hernia, again, there is a theoretical risk of strangulation. So Valsalva maneuver, it may be prudent to avoid. Hand grip and cold pressure test, some of the relative contraindications are severe hypertension in the patient on the day of the test. Better to avoid synthetic provocative maneuvers. Recent history of MI or reduced ejection fraction are also indications wherein these tests may be avoided, that may be prudent. We prefer head-up tilt test or tilt using a motorized tilt table in patients who are elderly, who have mobility issues, who cannot move their limbs because of paraplegia. Of course, it makes sense to use a tilt table. And patients with neurological or muscular disorder, wherein active and fast standing is not possible. So it is a good idea to do a head-up tilt test. One more word of caution, if there are multiple ectopics or movement artifacts in the ECG, it will not be possible to interpret and report HRV, and these tests should be avoided in patients who have multiple ectopics. So now we will quickly move on to do a quick demonstration of some of the techniques that are there. Let me give me a second. I'll just end my show. So I already have a power lab system in place in my room. I've connected these ECG electrodes. One of the leads are there. These leads are there on my body. You can see my system is able to detect the power lab system. This is a window that opens. Give me a second. So as of now, I'll just be demonstrating the ECG signal acquisition. I'll set up the system as I'll be requiring only 4 channels. ECG lead is already connected to my body and connected to the bioamplifier module. And as soon as I start, we can see that we can start getting a ECG signal. Right now, it is picking up mains noise. That is why you can see that the ECG signal is slightly noisy. We can go to the bioam settings and put in a mains filter here, which will improve the quality of the signal to some extent. So you can see now that the signal has become better, less noisy if you compare this part with this part. We routinely use a band pass filter for the ECG signal. So we will select as the source signal. I'm sorry, I'll just put in a band pass filter first. Yeah, digital filter. My source channel is my raw ECG signal. I use a band pass filter, which is commonly used. A high cutoff of 35 and a low cutoff of 0.5 Hertz. And you can see the signal quality dramatically improves and RR interval is clearly visible. In the lower panel, I can use the cyclical measurement function using ECG human as the preset. I'll switch to channel 2, which is better actually. So ECG human, I'll derive rates in the signal. And in the lowermost panel, I'll again use the cyclical measurement function and derive the RR interval or the period part. And when I start in real time, I'll be able to see my heart rate slightly on the higher side because probably I'm peaking. I'll remove the decimal places here and increase the decimal places in this. So we can record this heart rate signal for a period of 5 minutes, and then the signal quality should be good. If I move my hand around, moving the electrodes, you can see the noise that is there. So this movement artifacts will cause problems later and will preclude a good analysis of the ECG signal. So the subject should be lying still and the ECG electrode should be placed properly during the period of analysis. So I'll switch to a file that I've already saved on my system for the purpose of demonstration of analysis. Give me a second. So these are some sample data files I have. I have a subject's ECG file. So Okay, I'll close this window. I'd already done the analysis. That is why it's been, yeah. So this is a 5-minute ECG recording of a subject. To do HRV analysis, I can select a window, say of 5-minute duration. In this ECG analysis module, just give me a second. Yeah. So I'll go to the HRV analysis module, identify the channel. So my filter channel is where I would like to do the analysis. Define the normal intervals for the beat detection. I have chosen 600 to 1200 millisecond to be normal, and I am doing analysis for the selection window. So this is done. Then I can have a look in this HRV channel. Click analyze, look at the different plots that are available. So this is the tachogram plot, which I've shown, showing the RR interval as a variation of the interval number or as a variation of time. Then a point gear plot. This is a non-linear analysis method, plotting the next RR interval with respect to previous RR interval. And this is a power spectrum plot, which is showing the relative contributions of the fluctuations in the very low frequency band, the low frequency band, and the high frequency band. And we can also have a report here. I'll click on the report part. So for this subject, I'm getting a total power in the range of 5,000 and SGSG and RMSSG in the range of 93. This is a young adult male. He was 21 years old, in which we had done data acquisition as a part of the project. So this autonomic tone assessment is completely normal. Then let me quickly show you the other parts. So align to standing. Again, this is the line to standing transition, wherein there is an increase in the heart rate immediately after standing and a fall. We are interested in 30-15 ratio. So we can calculate 30-15 ratio. I'll just move my window to one of the sides. I've already created an Excel sheet for the demonstration of the analysis part. I'll move it to one of the sides and the data part here. Yeah. So this transition from line to standing part. So we can take the, I'll just expand the timeline. It is set to auto scale. So this is the shortest RR interval after the maneuver at around 15 beats. The value for this is coming in the range of 547 milliseconds. So I'll put it here, 547. And the longest RR interval after the maneuver is 755. So I get my 30-15 ratio to be 1.38 for this subject, which is in the normal range. Then showing a calculation of the deep breathing test. This is for another subject that is available. Yeah. So these are the values for deep breathing test, the record which I had shown. So let me take the maximum and the minimal heart rates. So for cycle 1, I'll just pull this out for you. It is coming roughly in the range of 83. The minimum is 56. Then here it is 82 and 55. Then in the next cycle, we have 77 and 54. Then 77 and 54 again. And for this cycle, it is 80 and 56. And for the next cycle, it is 81 and 55. 81 and 55. So here again, my delta heart rate comes out to be 25 beats per minute for this subject, which is well above the normal value, and EI ratio is 1.45. The last part, the assessment of the Valsalva maneuver. Open the file here. For the second subject, we had a Valsalva maneuver response. Yeah. So again, this is the strain part wherein Valsalva maneuver was performed. We can see a decrease in the RR interval. I'll pull this out again. So the lowest value comes out to be roughly 434 millisecond, and the largest value comes out to be 1180. So I'll put it here. 1180. Oh, I'm sorry. And the shortest RR interval is 434 millisecond, and the Valsalva ratio again is 2.7, which is well above the reported value, reported cutoff. Then for the blood pressure measurements, you can quantify the blood pressure responses to post-shoulder challenge, cold pressure test, and hand grip test, and you can document. You can make these templates in Excel by putting in formula, and you can use them, or you can even calculate this manually. Also, instead of deriving these channels, you can also select the ECG channel. For example, select this, do an ECG analysis using the selected channel, the filtered ECG, human, and calculate for every beat. Make sure all the peaks are selected, and you can also export the RR intervals and the heart rate based upon your region of interest. So this also can be done. What I showed here using a derived channel was a quicker method. But if you are having cutoff values which are very close to the cutoff, it may be a better idea actually to do manual selection and export all the RR intervals and then calculate them manually. So I'll just stop my presentation here and hand over the session to Dr. Kiran ma'am, who will tell you regarding the baroreflex sensitivity and newer techniques. Thank you so much.
Thank you, sir. Before we go into the next topic, there are a few questions. Make sure, there is a question, if the patient falls asleep during the resting HRV recording, would it affect the results?
Yeah, the falling asleep should be avoided. We ask the patient to lie in a noise-free, temperature-controlled room, preferably a dark room, but the patient should not fall asleep because sleep is shown to have the NREM and REM stages are shown to have the effect on autonomic nervous system, and sleeping should be avoided during the HRV assessment part. Subject should be awake.
Thank you, sir. One final question. What is the difference in the values derived from a 5-minute HRV and a 24-hour HRV?
24-hour HRV, we get all these indices. We also get an additional index that is known as SGANN. That is primarily done for Holter recording. The values are fundamentally different because in 24-hour HRV, you can also get the very low frequency and ultra low frequency band. But again, I personally don't have much of an experience in the 24-hour HRV recording. We are primarily working in the 5-minute window only. But yeah, the values will be different, and additional indices can be derived using this 24-hour HRV. That is generally as a part of Holter monitoring.
So thank you, Dr. Shival. On behalf of the entire audience and the organizing committee, I want to express our sincere gratitude for your outstanding webinar presentation on heart rate variability and Ewing tests. Your expertise, insights, and passion for the subject matter truly captivated us all and left a lasting impression. Your dedication to advancing medical knowledge and your commitment to excellence were evident throughout your presentation. The clarity of your explanation enriched our learning experience. We are truly honored to have had you as the keynote speaker, and we hope to have the opportunity to collaborate with you again in the future. Once again, thank you for your invaluable contribution to our webinar, and we are immensely grateful for your time and dedication. Thank you, Dr. Shival.
Thank you so much. There are some more questions. I believe we can take them at the end. We'll proceed with ma'am's presentation.
Sure, we'll take the questions at the end. Thank you. So moving on to our final topic, the newer techniques in autonomic variability quantification, including BPV and VRS by Dr. Kiran Prakash. Dr. Kiran Prakash is an excellent teacher and researcher presently working as an assistant professor at Government Medical College Hospital, Chandigarh. Under the mentorship of Professor K.K. Deepak and Professor A.K. Jarial, she has introduced a novel method for the assessment of cerebrovascular reactivity, delta cerebrovascular conduction index. For her research works in autonomic and cardiovascular physiology, she has been felicitated by the R.C. Shukla APPI Award for her best research in cardiovascular physiology, Young Scientist National Award in Physiology 2020, A.V. Tilak Parvi Devi Prize for her work in neuroendocrinology, and Devraj Bajaj Research Prize for her developing in new techniques. She is also a recipient of T.R. Raju APPI Award and the Best Researcher Faculty 2023. She has many national and international publications. Presently, she is working on many projects funded by ICMR, etc. Please join me in extending a warm welcome to Dr. Kiran Prakash to share her expertise on the newer techniques in autonomic variability quantification, including BP variability and baroreflex sensitivity. Over to you, Dr. Kiran.
Thank you very much, and thanks for this kind introduction. So good afternoon, everyone. Now I'm sharing my PowerPoint. So just nicely heard, listen about the heart rate variability, autonomic function assessment and the overview of autonomic function by our respected Professor K.K. Deepak sir and Dr. Shival. So I will be talking about the baroreflex sensitivity, blood pressure variability, and their role in the assessment of autonomic function. So we already have learned a lot about and listened a lot about the autonomic centers, their function, and how it is being very nicely explained, how it can be assessed by heart rate variability and autonomic reactivity tests. So with the advent of the measurement of the beat-to-beat blood pressure recording, and we all know that blood pressure is a strong influence is strongly influenced by the autonomic nervous system as well. So with these things, the few new parameters has been introduced in last 1 to 2 decades, and those are about the blood pressure variability and baroreflex sensitivity assessment. And similar to the classical heart rate variability autonomic reactivity test, these can be assessed during the resting period. That means the spontaneous changes in blood pressure are being recorded, their variabilities are being assessed. Similarly for the baroreflex sensitivity, or the system can be stimulated and the response can be assessed and quantified for the assessment of autonomic nervous system function. So first we will discuss about the baroreflex sensitivity assessment. So classically it is being quantified by changes in the heart rate or RR interval in response to the changes in the blood pressure. Now this change in blood pressure can be spontaneous during the resting phases or can be provoked. So provocation or change in blood pressure can be done by pharmacological or non-pharmacological method. So nowadays pharmacological method, that is by Oxford technique, modified Oxford technique, these are basically the blood pressures were altered by giving the drugs phenylephrine or nitroprusside, and then change in blood pressure was being recorded, and how the RR interval response to that change in blood pressure were quantified. Nowadays, pharmacological methods are hardly being used because we now have more physiological and non-invasive techniques are there. So by introducing Valsalva maneuver or head-up tilt or lower body negative pressure, we can change the systemic blood pressure and record the response. Basically, in my talk, I will be discussing about the spontaneous changes in the blood pressure variability or the baroreflex sensitivity and how they can be quantified and what is their role in the assessment of autonomic function. So for the spontaneous baroreflex sensitivity assessment, we have spectral method and the sequence method to quantify the BRS under their different domains. So here already we have seen very nicely shown by Dr. Shival how the beat-to-beat blood pressure or how the ECG are being recorded by the lab chart system, and further processing of data are there, and then we can quantify the baroreflex sensitivity. So for the analysis of baroreflex sensitivity by sequence method, basically the sequences, as the name suggests, sequence method, sequences are identified. So what are those sequences? So before going to the details, here just in the left side of the PowerPoint, we can see that the topmost panel is showing the beat to beat blood pressure recording, and the second channel is showing the ECG recording. Third channel is the derived channel, as already Dr. Shival has showed how to derive a channel from the raw data. So derived channel, there the systolic blood pressure is being shown, and the fourth channel is showing the changes in the RR interval. So we can very well decipher here with the fall in systolic blood pressure, there is decrease in the RR interval. Similarly, increase in systolic blood pressure causes increase in the RR interval. The reverse happens with the heart rate. So here the baroreflex system or reflex is working, and that's why with the change in response to change in the blood pressure, RR interval is showing the change. In the middle panel, the plot is the graph is showing the sequences. Now, what are those sequences? So basically, these are the consequent sequences of the three or more BP changes, and all those sequences has been identified based on that. Okay, BP will change by 0.5 millimeter, at least by 0.5 millimeter of mercury, and in response to that sequence, the RR interval has been changed by 5 millisecond, and the sequence correlation coefficient must be greater than 0.85. So all those sequences has been identified and have been marked, and we can very clearly see that all these sequences which has been identified are shown in two colors, either red or the dark green or blue, whatever you can, it is visible on your screen. So we can see that the red one is showing the upward sequences, blue one is showing the downward sequences. So either the beat to beat blood pressure spontaneously has shown the increasing trend or the decreasing trend, and accordingly the RR interval has changed. And these sequences has been identified, and baroreflex sensitivity by sequence methods has been calculated by averaging the slopes of all these regression lines. So the right side uppermost table is showing the various values. Classically, the baroreflex sensitivity is being reported as change in RR interval per unit change in millimeter of mercury of systolic blood pressure. So that red box is showing that the classically baroreflex sensitivity is depicted by this marker. But other parameters are also being shown, where the change in RR interval by change in mean blood pressure is shown, change in RR interval in response to change in diastolic blood pressure are shown. So these are the non-conventional marker of baroreflex sensitivity assessment. Also, in every box, you can see that number of sequences has been identified. So number of, here we are seeing in the middle plot, we are seeing multiple red lines. So number of sequences in that 5-minute baseline recording has been shown. And these number of sequences again has a role in deciphering the autonomic function. We'll get to know about in the further slides. So basically, by sequence method, we identify the sequences based on the following criteria, and accordingly change in RR interval per unit change in blood pressure is being depicted as the measure of baroreflex sensitivity. Another method by which baroreflex sensitivity is assessed is by the spectral method. So here, similar to the RR interval tachogram, which Dr. Shival has shown. So what is that? With change in time, there is how the RR interval varies has been plotted as a graph. Now what happens? Similar type of graph has been plotted with change in time for the change in systolic blood pressure or mean blood pressure or diastolic blood pressure, and that tachogram is being analyzed by fast Fourier transformation in the power spectral density graphs. So we can get the power spectral density graph of RR interval along with the systolic, mean and diastolic blood pressure. Now the coherence between these PSD, power spectral density graphs, the coherence between the RR interval along with the systolic BP or along with the diastolic BP or along with the mean BP gives us the alpha coefficient values. So alpha coefficient values in lower frequency band or higher frequency band gives us the alpha LF or alpha HF values for respective systolic or mean or diastolic blood pressures. And this again tells us about the different domain of baroreflex sensitivity. So BRS assessed by sequence method gives us the idea about overall change in RR interval with respect to change in blood pressure. But by spectral method in low frequency band, alpha LF values gives us about the sympathetic domain of the BRS. Alpha HF values gives us the idea about the parasympathetic domain of the BRS. So different, although the recording is same, but different parameters gives us the idea about the different aspects of the baroreflex sensitivity. So here I am showing few of our lab data where conventional BRS parameters has been shown. Conventional means that by sequence method, that change in RR interval by per unit change in systolic blood pressure and alpha LF and alpha HF values. So here we can very well see that in the disease condition, here I am showing the BRS values in diabetic patients as compared to the healthy subjects, and we can very well assume that yes, the impaired BRS is there in the diabetes as compared to the healthy counterpart. Similarly, in the patients of acute coronary syndrome, the impaired BRS can be significantly impaired BRS can be seen as compared to the healthy person. But what happens when we give some intervention in healthy subjects per se? So here one of our study I have shown where the baroreflex sensitivity and heart rate variability has been assessed in young healthy subjects, and their BRS and HRV has been assessed while fasting as well as after giving the 75 gram of oral glucose load. And at the end of first hour, when the relative acute hyperglycemia is at peak, we have again assessed the BRS and HRV. Now, it is obvious that, okay, subjects are healthy, they are young. So how come a simple 75 gram of oral glucose load are going to affect their HRV and BRS? So yes, we didn't find any significant difference during fasting as well as the first hour of their oral glucose load. Any changes in the HRV parameters and hardly any change in the BRS parameters. Only the LFHF ratio of systolic and mean has been shown here. But when we assess the number of sequences, which I talked about in the earlier slide, that how much number of sequences has been identified. When we assess the number of sequences identified, we found significant changes in the number of sequences during the fasting as well as during the relative hyperglycemic state. So we may hypothesize here that the relatively constant baroreflex sensitivity is maintained at the expense of increased oscillations in the ramp of blood pressure and RR interval. So oscillations in the system has increased to maintain the constancy of BRS in healthy young individual. So yes, we have the parameters, other non-conventional parameters, which are indicating about the oscillations or disturbance in the system rather than the absolute BRS conventional values. So we can look upon the other non-conventional parameters as well. So to look upon the different aspects of the BRS, many authors have, many papers are there in the literature, many authors have tried as well. So how come the fibers from the cloth of the BRS can be explored? So a very nice paper is there by Hunt et al. And what they classically, we assess the baroreflex sensitivity by the ratio of RR interval and systolic BP. And here the Hunt et al. Have further explored the BRS by assessing its mechanical or vascular branch and the neural branch. So we all know what is the baroreflex system. The carotid artery, because of increase or decrease in blood pressure, the carotid artery distortions occur. And accordingly, whether it is increase or decrease, accordingly, the signals are being sent to the autonomic centers. And from the autonomic centers, the effectors are heart rate and blood pressure by affecting the blood vessels. Now, to explore the vascular or mechanical branch of the BRS and neural branch of the BRS, the Hunt et al. Suggested for the recording of the diameter of the carotid artery and RR interval, ratio of RR interval by diameter for the neural component. So they suggested and they also evaluated, but the problem was that assessment of the assessment of the diameter of carotid artery during any maneuver by taking ultrasound measures and these things. So these were the difficult thing. But then also they have suggested something. And similar in that line, Paso et al. Also again suggested to how to decipher different aspects of the BRS. They suggested the measurement of cardiac branch, myocardial branch, and vasomotor branch of the BRS, baroreflex arc. So they introduced the interbeat interval in this formula, and they postulated that it is telling us, since the interbeat interval has been put in the formula, so they are suggesting that it is telling us about the cardiac branch, more of the parasympathetic component of the BRS. Similarly, for the myocardial branch, they have introduced the stroke volume in the formula, and they are telling that since stroke volume is there, they are telling us more about the sympathetic branch of the integrated BRS. For vasomotor branch, they have introduced the term total peripheral resistance. Now, total peripheral resistance, we very well know, depends more on the diastolic rather than the systolic. So as calculation of BRS by diastolic blood pressure from diastolic. In the previous table also we shown that we are getting the BRS values from systolic as well as mean as well as diastolic blood pressure. So diastolic blood pressure are telling us more about the vasomotor center rather than the whole integrated BRS. So how to go into the micro domains of the BRS, many others individuals have suggested. These very nice suggestions are there, we can incorporate in our future studies. So till now we have known that okay, many BRS per se is being affected, determined by autonomic nervous system, and they are being affected by internal. Even in the resting stage, there are many factors which are affecting these cardiovascular variability. The inherent variability of center neural oscillators are ultimately affecting the end organs. End organs per se are being affected by the central respiratory couplers as well as the peripheral respiratory system. Again, there is the role of baroreceptors. They give the output as well as they, from their feedback, the systems are being affected. And these such loops are present when the subject is completely in the resting stage. Suppose independent of assuming that okay, physical and mental rest is there, if some other external perturbations are there, then other players are still there. So while commenting on the BRS, BPV, autonomic function, we have to keep all these things in our mind. So now coming to the blood pressure variability. Now, what is the blood pressure? Heart rate variability, blood pressure variability, baroreflex sensitivity, all these are interconnected. So blood pressure variability has long been studied, but in the terms of long-term blood pressure variability, where from visit to visit, the subject shows the changes in the blood pressures. Even for the midterm blood pressure variability, day-to-day changes in blood pressure are being recorded by the doctors and are observed by even many a times when subject is monitoring his blood pressure by own, then he also see that okay, day-to-day variation in the blood pressures are there. Short term, within 24 hours, we can observe, we have seen that blood pressure variability is there. And short-term variability has been attributed more to the arterial compliance. Long-term or mid-term variability has more to attributed to the treatment compliance. So these things were there, still long blood pressure variability, these concepts were long there, and it has been found that more the blood pressure variability was, it was more associated with morbidity and mortality. But with the beat to beat blood pressure recording, very short-term blood pressure variability has been introduced, and it has been found that this very short-term blood pressure variability, which is being recorded by beat to beat blood pressure recording, this indicates us more about the autonomic function, sympathetic drive, arterial cardiopulmonary reflexes. Short-term managers are more being assessed by the very short-term blood pressure variability. And it has been shown that the increased subclinical organ damage, increased cardiovascular events and mortality, these things are associated with increase in the blood pressure variability of very short term. And it has been also noticed that variability, increase in blood pressure variability and associated morbidity and mortality are independent of the elevated average BP values. So suppose if the blood pressure is within the normal limit, 130 or at the borderline, but showing more variability, then again it is deleterious for the health and future morbidity and mortality. So, and keeping these things in mind, we again already have learned about that various factors are there. Again, BP is being affected by many factors. BP variability again is being dependent on many external as well as internal factors. Internal factors, vascular mechanism, cardiac mechanism, rheological, even blood viscosity. These mechanisms are also affecting, and external environmental behavioral factors are there per se. So all these things we have to keep in our mind and then proceed. So how we assess is basically the blood pressure variability. As here already has been shown by Dr. Shival, that heart rate variability, how we assess. Here the basal recording with the time scale in the x-axis, that with every time for each cardiac cycle, what is the RR interval has been plotted, and that is showing as a tachogram. So in the similar pattern with the time in the x-axis, and with every beat, what is the value of systolic or diastolic or mean blood pressure, that is being again plotted. And with this complex waveform, another various parameters are being calculated in the time domain as well as the frequency domain, similar to that RR interval HRV pattern. So here also we get the SDNN, SENN, SDSD, RMSSD values for systolic, mean and diastolic blood pressure as well as the power in the low and high frequency domain and their ratios. So these variables can be used for the assessment of these parameters indicate about the blood pressure variability. So as I already talked about one study where in the group of healthy young individual, we have introduced acute relative hyperglycemia and assessed various parameters, heart rate variability and baroreflex sensitivity. When we compared the blood pressure variability during the fasting and first hour of glucose load, we found significant difference in many of the parameters. Although in heart rate variability assessment, we didn't find any significant difference. In baroreflex sensitivity, we hardly find any difference in the conventional parameters. But blood pressure variability parameters showed significant difference in many of the parameters. Here we can left side of the graph, we can see many of the red colored values. So again, we can assume that yes, blood pressure variability is looking into those domains where probably the HRV and BRS parameters, conventional BRS parameters, are not able to look into, or probably they are looking some another aspect rather than which are being affected by the acute relative hyperglycemia in young healthy subjects. So many various parameters enables us to look into the different domains of autonomic functions, and again, we need many multiple studies to decipher the physiological meaning of those, how these are being affected in healthy condition, various physiological condition, in pathological condition. So still there is very paucity of data in the literature, available literature. In the right side of this slide, one of the study I am showing done under the guidance of Professor K.K. Deepak, the effect of yoga-based cardiac rehabilitation on blood pressure variability, baroreflex sensitivity in the patients of myocardial infarction. And there also they have shown, they have assessed the effect of yoga, and they found significant improvement in the baroreflex sensitivity as well as in the blood pressure variability parameters. So yes, these are the tools which can assess and which can quantify the changes in the autonomic function in the domains which are relatively untouched or unexplored by other conventional parameters. So we can say that blood pressure homeostasis is being maintained by the HRV, BRS, BPV, their mutual interaction, their mutual possibility. So classically, we know that, okay, for the maintenance of the constancy of the blood pressure, heart rate variability comes in, and with increase in HRV, the decrease in BPV is there. So blood pressure is being maintained with increase in HRV. More is the HRV, it is good for health. Lesser is the blood pressure variability, it is good for health. So this gives us the idea that, okay, HRV and BPV have the linear correlation. So we explored the correlation of the HRV parameters, blood pressure variability parameters, and what we found that conventionally when we use the systolic BP's parameters, they didn't show any one-to-one correlation with the heart rate variability parameters. But yes, the BPV, blood pressure variability parameters of the mean and diastolic blood pressure showed the significant, at many of the domains, showed the significant correlation with the HRV parameters. So how the things simply looked as a bird's eye view are not at the very fiber level. So when we go deeper and deeper, many aspects are there. There are inherent oscillations in the vasomotor centers, the end organ from which we are recording, other external influencers are there, which parameter can pick up which aspect we have to still, the literature, we need the researchers to explore those things. In the right side graph, I am showing the correlation between the various BRS parameters along with the blood pressure variability parameters. And in this, we have shown that, okay, more stable, more robust the baroreflex sensitivity, baroreflex system is, then lesser will be the blood pressure variability. So yes, that negative right side upper part, that negative correlation is justifying our thing, this thought. But in the lower part, right side graph, lower big box, red box is showing. Here the correlation has been shown between the non-conventional, that number of sequences parameters of BRS along with the blood pressure variability. And these number of sequences shows direct correlation. No negative correlation is there. Direct significant positive correlation between the mean and diastolic blood pressure variability parameters. So again, these are exploring the new domains of blood pressure variability, mean and diastolic. They are again indicating about the total peripheral rather than only the stretch parameters, stretch over the carotid arterial parameters, again showing that role of some mean parameters maintenance, the total peripheral vascular resistance. So each and every parameter is giving us a new property of these associations and these mutual cooperation. So again, we need further studies to explore the physiological meaning of all these parameters more deeply, in more applicable form, and basically ultimately research are there for the betterment of the people and patients. So we have to search upon the clinically more relevant parameters which are more which can early detect the mortality or morbidity or affection of any system. So with these words, I just want to thank you all and thank you for the patient listening. Over to the organizers. Thank you.
Thank you, ma'am. There is a question for you.
Yes.
Is there a specific reason for superiority of systolic blood pressure use in BRS over diastolic blood pressure or mean blood pressure?
See, BRS is baroreflex sensitivity, and baroreceptors are basically, as the name suggests, these are pressure sensors, but actually they are the stretch receptors. So they respond to the stretch, and maximum stretch is being felt during the systolic pressure rather than the mean or diastolic pressure. So classically, since the baroreceptors are more responsive to stretch and they are not truly the pressure sensor rather than the stretch sensor, so classically with systolic BP, BRS was being calculated. But the baroreflex is a loop rather than a receptor per se. So in addition to receptor, there are other parameters also. The neural centers are there, medullary centers of autonomic nervous systems are there, their inherent oscillations are there. So they are being affected by systolic and mean and diastolic parameters per se. Feedback loops are there, feedbacks are going there. So conventionally, systolic BP was used for the assessment of baroreflex sensitivity, but nowadays with the just I have shown you the few of the data that in many of the situation, even the mean and diastolic BP parameters have shown the difference rather than the systolic per se. So that's why systolic was being classically used, but there are the role of mean and diastolic BPs per se also.
Thank you, ma'am. There was few questions left out from our previous topics to Dr. Shival. Sir, can HRV be used as a tool for stress management?
I read this question. Actually, HRV is a monitoring modality. So in my opinion, this can be used for the assessment of stress. For example, you are using it in some cognitive tasks. So it can be used as a measure of stress assessment. If you couple this with biofeedback or say some techniques such as yoga or slow breathing, so yes, you can see the changes in HRV and use it for management of stress. But again, I will emphasize it is a parameter that is giving us an idea of the autonomic nervous system. You can couple it with some modality to monitor the progression or the effectiveness of that intervention.
Thank you, sir. There's a couple more questions. So I remember there was a question on 5-minute and 24-hour HRV recording. So it is the continuation. So the EA ratio derived from 5-minute record will differ from a 24-hour HRV.
Actually, EI ratio we derived in the context of the deep breathing test, so not in the context of heart rate variability. Yeah, but I will say that yes, the values that are derived from 24-hour HRV and 5 minutes HRV are fundamentally different. 24-hour HRV will give us an idea, as I said before, about very low and ultra low frequencies, giving an idea about the circadian fluctuations that are taking place, which 5-minute window will not provide. So yes, the values are different.
Thank you, sir. One more question. What is the difference between normalized unit and MS2 millisecond square in spectral analysis of HRV? Which is more relevant clinically?
The millisecond square value, that is the power in the respective bands, represents the absolute value. When we normalize these values with respect to the very low frequency power, so for example, LF normalized is LF power divided by total power minus VLF power. So normalization is done with respect to VLF power, then we can get the values in normalized unit. Both of them are clinically relevant. I have primary experience in working with both normalized units and the absolute units, and both can be used clinically. There is some amount of normalization that removes the effect of the respiratory band in the normalized unit value. Otherwise, both can be used.
Thank you, sir. One final question. Can you consider the values obtained by the Power Lab as a standard? And what about the thresholds that we have
Okay.
acquired?
Power Lab, again, I will say that Power Lab is primarily a hardware tool. What we are doing is we are recording the RR interval data and we are analyzing it. So we have experience with lab chart software, and again, not only us, multiple published papers are there for lab chart software, which have reported HRV values analyzed using the software. And these values are considered as standard because a lot of literature is available using this software. Anyway, in case you have some specific software available at your end, so you can export the values of RR intervals from your data and use some other software which you want to analyze and report the HRV values.
Thank you, doctor. Thank you so much for that answers. I think we'll not take further questions and we are running late. So thank you, Dr. Kiran. On behalf of the entire audience and the organizing committee, I want to extend our sincere gratitude to Dr. Kiran Prakash for an exceptional webinar presentation on the newer techniques in autonomic variability quantification, including BPV and BRS. Your expertise, passion, and dedication to the subject matter truly shone through, making it a highly informative and engaging session for all. Your comprehensive exploration of autonomic variability quantification with a focus on BPV and BRS provided invaluable insights into these advanced techniques. We are immensely grateful for your time, expertise, and unwavering commitment to advancing medical knowledge in this field. Once again, thank you for your invaluable contribution to our webinar, and we hope to have the opportunity to collaborate with you again in the future. Thank you, Doctor.